and something's
Good
wrong.
afternoon and welcome to Trachoma Live. I am delighted to be able to present our guest speaker for today, Professor Hugh Taylor. He is the President of the International Council of Ophthalmology and Harold Mitchell Chair at Indigenous Eye Health at the University of Melbourne. His current work culminates in many, many decades of his past experiences and the knowledge that he's gained through his own personal education. He heads the Indigenous Eye Health Unit at Melbourne University with a roadmap to close the gap for vision. And one of the areas that he has done extensive work in is the elimination of trachoma. He was the Assistant Director at the National Trachoma Eye Health Program back in 1976 with the late Fred Hollows. And he joins us today. Welcome, Professor Hugh Taylor.
Thank you very much, Lien. It's great to be with you.
Thanks, Hugh. Now, I might start off this episode with a question that Mark Hansen had back in the last episode that we missed. But let's talk about trachoma and the process by which the infection leads to blindness. Can you tell us a bit about that?
Yes, well, trachoma is caused by the infection with Chlamydia trachomatis. It's a sort of bacteria, and actually the infection is very different from any other infection that we really usually talk about. The chlamydia themselves date back to the time of the dinosaurs, 200 million years ago, and every species has its own chlamydia, whether they're birds or reptiles or mammals. And so we as humans evolved around chlamydia, not the other way around. And chlamydia itself doesn't cause much of a problem at all. If it did, we wouldn't have evolved. But it starts to cause problems when the infection is swapped back and forth frequently and people have frequent episodes of reinfection. And it's been shown that to go blind from trachoma, you probably need to have something like 150 or 200 episodes of infection. And that infection, almost all that infection occurs in the first 8 or 10 years of life. So the kids are being infected 2 or 3 times a month. So that's really important to understand trachoma, that need for that repeated reinfection. And the infection is only found in the lining of the eye, underneath the eyelids. And it's spread by the infected eye secretions. And of course, the tears drain through the nose. So it's the eye and nose secretions that spread the infection. So the kids are being infected, once a week or something like that. And so if we kept every kid's face clean, trachoma would disappear by the end of the year. But the response, the disease that you see is due to an immune response to the presence of the infection, not the infection itself, but an immune response. And the more frequently you have that inflamed immune response, the more scarring there is. And that scarring underneath the eyelid, with time in older people, will contract and turn the eyelid inside out, so the lashes start to rub on the cornea or the front clear part of the eye. And that's, first of all, very painful, but also in quite short order goes on to cause blindness. And so it's a whole process that really based around those repeated episodes of reinfection.
So in order for somebody to develop the blindness, really, they've endured quite a long time of suffering, haven't they?
Exactly right. They will have had the inflammatory response, which we see as these trachoma follicles underneath the eyelid, and they will have been there for most of their childhood.
Now, Sol yesterday was telling us that the Royal Victorian Eye and Ear Hospital really had its beginnings in being created for the treatment of trachoma in Australia. So it was a very, very long time ago that trachoma affected mainstream Australians. What does trachoma look like in Australia today?
Well, trachoma, the Eye and Ear Hospital here in Victoria is one of dozens, or in fact hundreds, of eye hospitals around the world that were started in from the early 1800s through to the end of that century, specifically to treat trachoma. And the first specialist eye hospital we know of was Moorfields Eye Hospital in London, which was again started as a trachoma hospital. But trachoma disappeared from mainstream Australia really 100 years ago. in the early 1900s, the head of the Idea Hospital wrote in a paper that he was really having problems. He couldn't find cases of trachoma from Melbourne to show the students. He had to bring them in from the Goulburn Valley and the Western District. Basically, with the improved living conditions in Australia through the early part of the 1900s, trachoma disappeared.
Mm. And so now I know that many students of optometry and ophthalmology aren't aware of trachoma in Australia because it only exists in some of the remote communities out bush.
That's right. Trachoma persists as a problem in the Aboriginal communities, mainly in the outback areas and the hot, dry areas in and around Central Australia. So that if you're practicing in Melbourne or Sydney or Brisbane or somewhere, you're not going to see cases of active trachoma. You may occasionally see people who have inclusion conjunctivitis and acute, self-limited chlamydial infection, and you will see people with trichiasis, the interned eyelashes, but usually it will not be from trachoma but from some other cause. So most Australian optometrists and ophthalmologists are really not very familiar with trachoma, although they might have learned about it in a textbook when they were training, but think of it as a historical accident.
Absolutely. So why does trachoma still persist in these communities, Hugh?
Well, trachoma persists in areas where the personal and community hygiene is poor, so that the infected eye secretions are transmitted from one kid to another, so that the children are getting those frequent episodes of reinfection. So that what we need to do is we need to stop that frequent transmission of infected eye secretions from one kid to another.
Now, the Australian government have actually invested significantly in trachoma elimination activities since about 2009. Can you talk to us a little bit about that?
Yes, well, there was some work done following the work we did with the National Trachoma and Eye Health Program in the 1970s through the 1980s, but it wasn't terribly effective, and it was really focusing around just treating kids with antibiotic ointment. And through the 1980s and early 90s, there was a lot of work done, some of which I was involved with, that showed we actually needed to do several things to address trachoma. So WHO developed what they call the SAFE strategy, which includes the surgery for the interned eyelashes, that's the S. The A is antibiotic treatment to reduce the levels of infection. F is facial cleanliness to really keep the kids' faces clean to stop the transmission. And E is the environmental improvement, so the children can actually wash their faces properly. And so that SAFE strategy was brought in the 1990s and adopted by WHO as the strategy to eliminate trachoma. And it took a while for Australia to do much about it. And we had to collect enough data, and we were able to convince Kevin Rudd, when he was the Prime Minister in 2008, to make a commitment, which he made in 2009, for Australia to eliminate trachoma by 2020. And since then, they've been funding the state-based teams who do the screening and treatment with the antibiotic of the children and the families that need it. But there's still more work that was needed to be done in terms of the health promotion, the F and the E components.
Sure. So just back to the communities that are affected or at risk of infection, can you talk to us about those and where they're located?
Well, when we started this in sort of 2008, there was something like 220 or 230 communities across Northern Territory, South Australia, Western Australia, and bits of Western Queensland, Western New South Wales that were thought to be at risk of having trachoma, or at least had trachoma in the past. Now, some of those communities, when they looked at them, particularly the ones around the coastal areas or the larger towns, because of living conditions had improved, trachoma was no longer a problem. But there remained about 150 communities where trachoma was still at endemic levels. And since then, over the last 8 or 10 years, the rate of trachoma has dropped dramatically, so that it's gone from 21% in 2008 down to about 4.5% now. And while there's still a number of communities that have low levels of trachoma and a handful of communities that still have unacceptably high levels of trachoma, most of those communities are in the area in Central Australia, the south half of the Northern Territory, the Eastern Goldfields in WA, and outback areas in South Australia. So we are actually making some really good progress, although we've still got more work to do.
That sounds like incredible progress, really. That's an incredible achievement there. One of our viewers yesterday, Beck, had mentioned the community of Kintor, whether that particular community had been affected. Do you know Professor Hugh Taylor?
Yeah, well, certainly Kintor, which is one of the Walpuri and Pinnabee communities right on the border of South Australia, Northern Territory, WA, has had problems with trachoma, as have the other communities like Papunya and Mount Liebig and Kirakara, which are all sort of linked together. And but the rates there are also coming down compared to what they were.
That's great to hear. Now, final question, Hugh, what do we need to do to eliminate trachoma from Australia forever?
Well, what we need to do is we need to change the community norm so that it's no longer acceptable for kids to walk around with dirty faces. So it's to keep every face clean. And the message we use in the community is clean faces, strong eyes. So that if every kid's face is kept clean, they're going to keep on having good vision through the rest of their life and they won't be at risk of trachoma. The message about the health promotion, we've done a lot of work with health promotion with support from a number of different groups, including private donors and the Commonwealth, and promoting the message about clean faces and strong eyes. And we find that over 86% of the community know and recognise and understand that message. The problem we're facing now is that in so many of these worst communities, the children just cannot actually wash their faces because the taps and basins and things in their houses or at the schools don't work or are not functional. So our message for people in authority and so forth is clean faces, safe bathrooms. It's really important that we have safe and functional washing facilities. And so it's to make sure that if a tap doesn't work or a drain's blocked, it's fixed within a day or two. It's not acceptable to have to wait 3 or 6 months to have that attended to. And so I think what we really need to do now is look at that health hardware, focusing very specifically on what's required for the children to be able to wash their faces.
Absolutely. Now, we've got a final question here that's just come up. Are there any other specific communities that Rotary should target with the F&E strategy?
We really need to look at the 50 or 60 communities that still have trachoma, which are the communities, as I said before, in sort of the, in the Northern Territory, the Katherine, Barkly and Central Australian regions, the Eastern Goldfields, the APY lands, and then the far west regions in South Australia. And so, in each of those communities, there will be at least some families or some children in families and household there who's got trachoma. And we need to look more specifically and talking with the state and territory people to target the communities. Most of the information on which communities have which prevalence is all de-identified because we don't want to sort of name and shame those communities. And so that's a discussion that needs to be taken offline.
Yeah. And that just means our work to identify communities and work with communities is that little bit more difficult.
Yes, I understand that. But again, it's linking up with the trachoma coordinator and the Aboriginal Community Controlled Health Services in each state or the territory and having a conversation with them to identify which communities they think should be targeted and coordinated. And I mean, we've got to remember that we need to be doing this with the Aboriginal people and the communities, not to the Aboriginal people and those communities.
Agree 100% with you there, Hugh. And finally, my last comment would be our targeting the F&E strategies isn't just going to end trachoma, but it could have some really positive flow-on effects to other infectious diseases that exist in the community.
Well, that's absolutely correct. We've got an unambiguous, fine focus and concentration on trachoma. But our 5-step hygiene message, for example, is blow your nose, but actually it's not blow your nose, it's blow your nose with the tissue until it's empty. Wash your hands with soap. Wash your face whenever it's dirty. Don't share towels, and brush your teeth twice a day. Now, that not only has a huge impact on trachoma, but it also otitis media and deafness, the upper and lower respiratory tract infections and bronchitis, gastro and diarrhea, and the skin infections, the scabies and so forth, that go on to lead to rheumatic heart disease and kidney failure. So that by focusing on good hygiene, we actually have a very broad impact on the health and well-being of these people and children, not only today, but for the rest of their lives.
Absolutely. Thank you so much for joining us, Professor Hugh Taylor, everybody. We are delighted to be working with Professor Hugh Taylor on this initiative. He is leading the charge in Australia. So we are very grateful for your support, for linking us in and for introducing us to all the people who need our support. Thanks, Hugh.
Okay, Lien, thank you. It's been my pleasure, and we're delighted to have the Rotarian support. Thank you all.
Bye. That was Professor Hugh Taylor. Thanks for joining us on Trachoma Live. Tomorrow we have Professor Kerry Arabina to talk about Indigenous health equity and how we work with and not to Aboriginal people. Thanks for joining us today. I will see you tomorrow with Professor Kerry Arabina. Bye for now.